Welcome. Thank you all for coming. It's my great pleasure to introduce my trusted colleague and journeyman, we'll describe that in a minute, who's Stephen Critchlow, who's Chief Executive of the Evergreen Group, who's come all the way over with his passport from Manchester today, just a little bit north, to talk to us about people-powered health and really making data work for citizens rather than citizens work for data in a world that aspires to more connected health. But how does this evolve? Stephen will enlighten us as to what he's doing with the Evergreen Group. We're just sharing a story. So as soon as background, he was doing pharmacy at the time that I was studying pharmacology here in Liverpool. So either end of the M62, we were boiling test tubes of urine for sulfadimidine assays, but both slightly misbehaving and writing software for fitting calibration curves. And that software writing for Stephen carried on. In his career, he went to spend 15 years in the NHS, where he rose to board level. In 1995, he founded Ascribe, which became a very successful company, building clinical systems that for pharmacy covered 75% of the NHS and spread to other parts of the world. In 2013, he sold Ascribe to EMIS, and in 2014, he founded the Evergreen Group, and he's become a very successful social entrepreneur focusing on health and sustainable energy. So without further ado, I'd like to invite Steve to give his talk.
So thank you very much for inviting me in, and I just wanted to check who we'd got in the room, really. Various people who may have been to NHS meetings, or the kind of NHS staff here. Yeah, okay. And I believe there's some university people here. And I have no idea, but we asked a few people who might have been patients or people. Have they come? There are a few of those? Not? Oh, one or two. Okay. So for those who've been involved in the NHS, can anybody think of a time when you've been to a meeting where it gets to the end of it and somebody says, does anybody remember to talk about the patient? Yeah, you have. You can certainly tell that. Well, what this is all about is saying, what happens if we think of the patient first at the beginning of those meetings or at the beginning of everything that we do? Putting the person in charge, giving them the power. So you might say, well, what experience have you got that means that that's even worthwhile? So I thought I'd just tell you a few of the stories about my own life, about things that either went well or went badly, and how I believe that when it goes well, it's because you focus ultimately on what the person needs and wants. So yes, in those early days, pharmacokinetics, I'm going to use an example I wasn't going to use, but I carried on and I decided to look at gentamicin levels, if anybody knows that as a drug. And initially I was trying to apply the same things I'd learned at university about population pharmacokinetics, and believing that I would never get there. It's a really complicated subject. The levels I'm getting are all over the place in comparison to what I was predicting. So I decided to go to the wards and see what was actually happening. And what I found was that the time that the nurses actually gave the dose to the patient bear no resemblance to what they said it was going to be, and that the labs were using a method of measuring the gentamicin, which was so imprecise. It was more imprecise than anything I could have envisaged in my own model. And so actually I corrected the other end of it, which was the measurement of the level, which was actually right at the patient's end and thinking of it from the patient's end. So I think that applies there. I then saw a change in the way that we were treating patients in one of the first jobs I ended up as a manager in, which was at the Children's Hospital, where we were treating patients predominantly with leukemia. And roughly 30% of those died of an infection during their treatment. And then when we looked at why, there was a direct correlation between the manufacture of their total parenteral nutrition, which is feeding the patient through their arm when their stomach's not working as they're having their chemotherapy, that if that was made in the sluice on the ward, the person was very much more likely to die of an infection than if it was made in aseptic conditions in the pharmacy. Now many of us, including me at that time, turned up feeling very proud that we provided the service we were asked to provide. So we were expected to do 7 bags a day. So we could do 7 patients a day, and that was a good day at work when you went home and you'd done 7. But we then said, well, if this infection problem is caused by the nurses, how many doses do we need to make to mean that we do all the ones for the people that need them? And the answer to that became in the order of 25 to 30 TPM bags, but more than that, the 6,000 per month, by the way, injections that were being made on the ward by hand as well. So by focusing on the need of the person and deciding to change that, which was we built a unit on the site that made injections, and providing some software to do the calculations, moving on from the work that Ian just described, we were able to drop that infection rate to a fraction of what it was before. And the satisfaction that comes from that, and the drive it gives to your own staff in the department to say, there are people now walking out the hospital that wouldn't have done before. So that gave me a lot of personal success, because the hospital could see we were doing something that made a difference. And you just carried on. And you said, well, okay, what about the way we do pharmacy? Well, generally a pharmacy in my days, those days, you had a piece of paper handed through a hatch and preferably shut it as quickly as you could to stop any of the people who might disrupt you from putting the tablets in the bottle accurately and making sure the label was straight. And I thought, well, this isn't the thing I learned to do. This isn't what I was trained for. So what about we do something to mean that people can actually go, the pharmacists can go out with the people who are in the beds and talk to them there about what they're on, and talk to the clinical staff about whether it's the right drug for them, whether the drugs interact, all of those things that I'd spent years learning. So that's where Ascribe was born, and I didn't write the specification for what the NHS was asking for, just like I didn't do the project that the university said I should do. I decided to focus on what I thought the people in the beds actually needed. So what we did is build software that would do interaction checking. It would do dose range checking. It would record all the drugs that people would dispense for by name, so that the pharmacist could be sitting at the patient bedside with, in those days, a laptop computer, because it became web-based by the time we were doing this, so that they could talk to the patient about what they were going out on. They could do all those clinical checks that they were trained to do on the wards. And what then happened was we were able as a company to drive that through to success, to mean that 75% of hospitals have ended up using that today. And so as I got to that point in 2013, where it felt like almost the end of a journey, to have built a company that by then didn't just serve pharmacy, it served all of the different departments in a hospital with the same kind of values, you could say, well, and that became part of EMIS Group, which is then both primary care and secondary care. You could say, job done, end of story, you've done a great job. And I stopped to think. And I just thought, am I really thinking about the people and everything that we do? Because we were coming across a really difficult problem in that, at the end of that journey that I was on. And that was that patients didn't have the data available for each organisation they were going to. The NHS has become more and more specialised. Our country breaks down the problem of health into lots of different specialisms that treat people. And when the people we were trying to serve within Ascribe used to be in district general hospitals where everything was done in the same place, they were now going on a place where there are lots of different legal entities with their own way of handling data. And that became the fact that the data wasn't available at the point of care, and it was stopped by data sharing agreements, and particularly GDPR on its way. And that started the idea of saying, well, could we do this completely differently? Could we be completely centric in the way that health IT is done? Is it possible to mean that the person can arrive in front of every clinician with their health record in their hand, knowing that they've got a complete record and they can be safe, and that the clinicians can actually work, knowing that they've got all the information they need? And so this simple premise of putting the patient first, decided to apply that. And what we basically said was, if the person themselves can own the data and be their data controller legally, that means that they can share the data with whichever organisation they go to. So all they need to do is be given the permission to own it and let the organisation share that data with them. So there are a few technical slides, because I thought I was coming, obviously, to a university. They're very, very diagrammatic, but we'll go through. For anybody who has worked in the NHS, in IT, this diagram will appear familiar. For anybody who hasn't, it'll look like a complicated mess. Okay, so it's probably both in real life. This demonstrates a typical hospital. They'll have something they call a patient master index or master patient index or whatever it might be called. That's usually part of their patient administration system. And they'll map the IDs that uses to each of the IDs that each of their departmentals use to put together a record that often they can show to, even to people, as a portal. And that is often called a personal health record. So these are stitched together by the IDs each of the departments use. To make one of those work, generally, with GDPR, it has to be within the same legal entity. Otherwise, you have to have data sharing agreements to send the data elsewhere. Okay, so but what happens if we think of it differently? And we say the person's in the middle. So the personal health record starts to be created by sufficient that wherever you turn up, you have your ID. So that might be the NHS number, it might be the ID of the hospital that you've just been to. It might be something that you know. It might be that if you combine something you know, something you have, and something you are, you've got a pretty high chance of identifying the person. So what you know might be your mother's maiden name, what you have might be your passport, something you are might be your face print or your thumbprint. So we can use the something you have, something you know, something you are to identify you, and we can use IDs to associate with the data in each of the areas where you've had your care. And if that sat within your health record, you don't need a master patient index anymore. You just need them to know that you are that person. So that goes into your record. And then on top of that, you start entering your own personally entered data. So that might be scans of the documents you've received through the post. It might be blood pressure readings from your home blood pressure monitor. It may simply be the drugs you're taking to be reminded to take them. So we started off in Evergreen saying, we'll build one of those. What we'll do is we'll make it so that you can manually enter things and you can put all of your IDs in. And we were very lucky to have a number of people start to use it. One of those people who can't be here today is Cancer Mum. She doesn't like her name being used, and she follows us on Twitter and puts some nice stories out. Her son was actually diagnosed with a brain tumour. He had an operation, and part of that operation was to put a metal plate in his head. And all of that happened at this point of entering the data. If you imagine now, where we start to put all the other data from other areas, which for her was GP data as well, all into that record. We've now got a full data record for the person, which contains the ID. This has the capability of being connected to anywhere that you go, internationally, globally. It doesn't matter anymore whether you're in one of the 5 Lycas that are all doing the separate MPIs. It doesn't matter whether you went from one hospital to another and they don't know about you. You've got the record with you. Okay. So basically, that's the starting point of Evergreen, of me having, I'm saying me, there's a lot of people in the room who did the same. We were all in Ascribe together, realising we had this problem. And we rationalised that this would be the biggest thing we could do to turn healthcare upside down. It's difficult making it complicated because it's relatively simple. The patient owns the data, they're their own data controller, they take data from wherever they are, and they offer data wherever they're going. And that's what this diagram is there to define. And we certainly believe having done many of these difficult projects in the NHS to integrate things, that by doing it that way and putting the patient first, it actually delivers exactly what we need in healthcare, which is to be able to travel between all the different specialisms where the data is mapped to the current system and available. So how far have we got? Well, we've got about 650,000 registered users. Around 430,000 of those are linked to their GP in England. We have a national capability to link every GP in England, except a few in Cornwall, 99 point something%. So you can go into your GP today if you want to. You can download Evergreen, it's available on the App Store, and you can link to your GP. We are an NHS-approved app, and we're following the NHS way of doing that. We get about 1.5 million transactions a month. That's people who place appointments to the GP, order repeat prescriptions, download their health record, and send messages to their GP. Having realised that the data was the key to unlock things, and been to places where I, probably controversially at the time, said, I think we can turn healthcare upside down. We can put the patient at the top and everybody else supporting them by simply turning the data model upside down, putting the person at the top. And obviously people start to say, well, what else will change? And you start thinking about that. And you start to realise that actually, in virtually everything we do in healthcare, we have a tendency to think of, just like I thought of that point where it was good to do the 7 TPM bags, and that was my job done, I could go home with a clear conscience, that we kind of are slightly blind. It's slightly hard to say, but what did the patient really want? What is it that they needed? And so you start to go through each of those things, and you start at the very starting point, which is that generally, I would argue, the NHS and health systems globally tend to engage once you're sick. Because that's at the point when you can start to provide value. It's the starting point that drug companies can commercialise things. But not many people look at what you would do to stop being sick. Because why would that give a reward to people generally? And if you take general statistics, you've got things like 135 billion spent on the NHS. All of us spend around 40 billion on private healthcare initiatives. As simple as buying over-the-counter things from a pharmacy, right the way through to getting bupa. Wouldn't it be great if we could help people spend that 40 billion to avoid being sick? So I'm going to tell you a story that influenced us all as it happened. And that is that we were testing the app. We had a number of our staff were using relatives who might be using services to test out what it would be like using it. And one of them had a mother called Margaret, and she was going to various different specialist centres. Initially, a slight rheumatology problem that then became an ENT problem with weeping ears, then a chest physician ended up with them, then a cardiologist needing a pacemaker. She then went blind in one eye. Actually, along this journey until they're going blind in one eye, back at the office, we were relatively celebrating how life would be looking for all those people once they started using the app that we were testing. Because Margaret was repetitively asked the same things, the same tests were done multiple times, none of these areas were talking to each other, and you'll be pleased to know this is all in Manchester and not in Liverpool. So I'm sure it's fine here. She eventually ended up with 14, I think you counted 14 different legal entities looking after her. And there was a real point where we said, well, instead of just being passive and seeing this as a test, we should actually let it be used. And that was when her daughter rang me and said, I don't know what to say, Stephen, but my mum's gone blind in the other eye. By this time, she'd had the first eye taken out because it was thought to be cancerous. And she said, I don't know how I can look after my mum, blind. And so I said, well, just let's try and use the app for real then. Because she was a nurse, I was a pharmacist, and we both often would say, well, nobody has 7 different unusual complications all at the same time. This doesn't make sense. So why not use the multidisciplinary team meeting to find out actually what was going on? They did. She had one disease. And so she had vasculitis, which has one treatment, She was treated with that, and she did keep her eye on her sight for the rest of her life. A lot of the treatment that she'd had for the things that weren't really wrong with her means that she's not alive today, but it gives great hope. So what happens when you join the data together in this way, if people then use it? So I thought I would just tell that as a story so that you can understand what we're trying to do. If Margaret was in the position where she could walk into every place that she went with her data, then she would have had a completely different outcome. One person who has had a completely different outcome goes back to the lady I told you about, called Cancer Mum, who entered her data at the beginning when we were first testing out the manual way of completing your own record. She needed to, her son needed an operation to replace the plate in his head a few years later. So by now we were linked with GPs. They wanted to put exactly the same metal in the boy's head. By the way, he'd recovered so well, he'd gone to Cambridge to get a good degree. He's perfectly fine. He just needs this operation to make the plate a bit bigger. But nobody could find the records of the metal that the plate was made of. Okay. Now, what this lady had done is she had actually, within Evergreen, put the records herself under a title. So she could go back and she found the metal and gave it to the hospital, and the operation was done. She's a very big supporter of ours. She wanted to be here today, but she lives in Kent, so it's quite hard, and she apologised yesterday that she couldn't make it. The boy had a successful operation, and she's sure he's alive today because of the access to that data that the NHS couldn't give her. So I've just mentioned a few stories, and what I'd like you all to do, if you can bear with me on this, is that these are a few people that I think about each time we're going to make a decision. Can you all stop and think of like a person you know and love, or maybe just anybody you can remember easily? Because I'm going to go through a few things I think can be different, and what I'd like at the end, if we can, is challenge me and everybody else with, will this, if we started to work the way I'm about to describe, would that mean that the person you're thinking of would actually get a better deal? Would we put them in charge? Would they have the power in the patient's hands? Is this the right way of working? So if you look at the problem we have today, going beyond the data, how is healthcare today? You could say it's very simple. You know, we get born, we then get sick, and then we die. There's a new term being bandied around called health span as well as lifespan. It's in the 5-year forward view, and it's mentioned there as being that we have 18 years from getting our first long-term disease and dying when we do it 82. So at 64 on average, most of us will have something that's being treated. This is one of the reasons that the NHS is now getting to it, crumbling at its knees. I don't know, this morning's news is all about how 2 in 3 GPs actually leave their job. Only 1 in 3 stay in their job. We've got something like 1 in 4 of them who are clinically depressed. And it's not a job people like doing because we have massive waiting lists in our hospitals. People can't get the appointments that they feel they need and deserve, whether it's with their GP or whether it's having surgery. And that's, we believe, driven as much by the expansion of those years that you're ill as it is by lack of resources. Because the simple fact is, as you plot the progression of the changes in health dynamics, in roughly 15 years, we will be using all the healthy people to look after all the sick people, if we carry on with the same progression in healthcare. And I was only saying this morning, working in both sustainability and health, today's about health, it surprised me actually that the initiatives that are in the press at the moment about sustainability have caught the public imagination quicker than the problems we have in health. Because actually, just like we're saying we shouldn't be talking about climate change, we should be talking about climate crisis, I think somebody needs to highlight the fact that we are slightly fond of our NHS. I love it, certainly. but it is struggling, and it's struggling so much it needs to be helped. The thing that we believe it could be helped with most is to reduce those 18 years. How can we help people not get sick? How can we reduce the demand? That doesn't mean to say we need to do something to help people when they are, but if we could reduce those numbers, we might be able to cope with the demand. So something about it is to do with DNA, in that we can predict those things that you should focus on individually to mean that you will have a long life, and we can do that today. Evergreen does have a DNA test that attempts to do that, so we can predict things like your likelihood of being short of a vitamin. We can predict what your carbohydrate metabolism is. Do you really have to worry particularly about getting type 2 diabetes, or you're not really one of those people? We can predict your fat metabolism. We can also start to pick up signs that you might become diagnosably ill later. It's a question, are they symptoms or are they wellness indicators? We're challenged within Evergreen to know what they are, but they are little things that happen that start to tell us that we're not quite right, that we could actually pick up on, that generally healthcare doesn't today. In other countries, that 18 years is significantly less. In places like Sweden, it can be, depending on which paper you read, 3 to 9 years as against 18 years. So why? If you look in Sweden, for example, in Sweden, everybody there, as part of their education curriculum, has education on diet, fitness and lifestyle. They focus particularly on mental health, they focus particularly on the way you engage with the community in their curriculum, and they assess every school in the country in the same way that we may do with Ofsted. Is that the cause? Is that the reason? How early can we start from when people are born to be sure that we have them on the right track, not to have long-term diseases later in life? The other thing is that most of the interventions to mean that we live longer have been things which also don't deal with the sickness we have. So we've extended life, but we've not reduced the sick years that we have. And that's generally because we have a society that praises people for doing that. How many people would look at research into things like ketogenic diets and cancer? Because where would you get the commercial benefit from doing that? So actually, if you look at the players in health today and ask whether they are driven by the needs of people and how would we change that, generally, whether it's politicians who talk of citizens and not people, are talking about what can they do to mean that we will vote for them. I've been lucky enough to be part of the setting of manifestos for health with both the Labour and the Conservative Party, because I'm not particularly politically swayed either way. And with both of them, they are unlikely to reduce the number of nurses, because it's cheaper to have a nurse employed than it is to have somebody unemployed. And that drives a lot of the decision making. For example, for politicians, they are thinking about why will people vote for them rather than what is the best and effective care. If you look at banking and venture capitalists who are supporting companies who are attempting to change healthcare, obviously they're looking at their financial return and drive for something that will do that. They'll want to sponsor things that are patented. They're wanting to sponsor things that will give a return in the time frame that they're giving them. Research ends up being funded by the people who will pay for it. There's lots of evidence, very bad place to say this, but there's a lot of evidence to say that you're more likely to give the right result to somebody who may pay you next. So is research done for people, or is it done for the drug companies that pay for the research? I missed off health IT businesses there. Did you notice? There's a cognitive bias in us all. Health IT businesses end up having to deliver the project that they've been told they must deliver, and you end up proving you've delivered the function, not proving you've delivered the outcome. And however hard you may want to run a business to do that, it does feel quite difficult. So I'm going to give you the first signs of hope. In changing the way that we look at things within Evergreen, we're starting to get just the first glimmers of data out of some test users as we are hoping to score wellness, to help people understand how they can increase their health span. You can see here that the younger group has a relatively poor diet. So people up to the age of 40 to 60 are on average getting a roughly 20% of them have a significantly bad diet, where once you go up over the age of 40, you can see that's more at 5%. There's almost a complete switch. Now we're literally, this is hot off the press. We are not researchers. We don't know whether that is correlated correctly. All we know is there's something going on. So what we're doing at the moment is we're building a data model to mean that we can look at every aspect in those personally owned health records where people have embraced the concept of being a data donor on our app, and trying to build models for organisations like this to do some research on. And we're proving that that's possible. So that's what this is about. We have 650,000 users. This is just a test questionnaire to 1,000 of them. We got it off quite quickly, Paul. and that's the result. But can you see how that starts to beg some questions? Should we be going back and doing education in schools to people who don't know about diet when the 16 to 25-year-olds obviously have such a bad diet? For those who end up looking at the numbers, because I imagine there will be somebody like that, you'll notice how the difference in the correspondence from females and males as well. Most males aren't answering, and you get roughly 3 times the response from males. So what we're about to do is bring out the whole concept of having a well-being score, and the app will look like this in a few weeks. As you first go into it, you will see a score in the middle, which is your general wellness score, and then each of the different areas where you could contribute data, you can see how complete that is. So if there are grey parts of the diagram there, if you click on them, it'll give you the ability to fill in the rest of the data. We're building a data model that will mean you will know whether you're well or not. And attached to that are intelligently produced pieces of information that can help you understand what you might do in that circumstance. As you start to drill into it, maybe you drill into your diet. You can see there are other things you could do, other questionnaires you could complete, or maybe other initiatives you should take. And again, you get the overall wellness score in that area. So we believe that what we've done in Evergreen is put the person first and said, how can we put them in control? How can we change the way that data is handled to mean that they are the top of our thinking? This is an appeal to all of you because you're from universities, the NHS, and academia generally. I believe we should all allow people and help people to own their own data. It doesn't mean it belongs to us as a company, it belongs to them, and allow them to transact with it, both to improve healthcare as data donors and also to enjoy the healthcare that they need when they see another healthcare professional. So if you're I'm appealing to anybody who's working on any projects to think that way, and also now as we go into question time, to challenge that thinking. Where does it fall down and where does it help? So thank you very much for your time.